This presentation is on hormone replacement therapy, counseling on risks and benefits by Casey, Erica, Shauna, and Susan.
The media attention surrounding the publication of the initial results of the Women's Health Initiative in 2002 led to fear and confusion regarding the use of hormonal therapy after menopause. This led to a dramatic reduction in prescriptions for hormone therapy in the United States and around the world. Within months, the number of women using HRT dropped by almost half. By 2009, HRT claims had dropped by more than 70%. This significantly disadvantaged an entire generation of women. Although in 2002, it was stated that the results pertained to all women receiving HRT, subsequent studies clearly showed that younger women and those close to menopause had a very beneficial risk-to-benefit ratio. On the other hand, women who initiate hormone therapy more than 10 years from menopause onset or are 60 or older, the benefit-risk ratio appears less favorable because of the greater absolute risks of coronary heart disease, stroke, venous thromboembolism, and dementia. Furthermore, delayed use of hormone therapy seems to be associated with increased level of Alzheimer's disease markers in the brain, while earlier use is associated with few of those markers. So why didn't academic medicine and the NIH tell us all of that until years later? One must follow the money for that to become clear. The NIH and the academic institutions took money from the pharmaceutical companies and only studied those drugs paid for and manufactured by those same sponsoring pharmaceutical companies. The Women's Health Initiative didn't study all forms of HRT. They omitted human identical or bioidentical hormones that behave completely differently and have decades-long track records of safety. When things went wrong with the study, all hormone therapies were labeled as bad by the medical societies such as ACOG and NAMS. Hormone therapy remains the most effective treatment for vasomotor symptoms and the genitourinary syndrome of menopause and has been shown to prevent bone loss and fracture. The risks of hormone therapy differ depending on type, dose, duration of use, route of administration, timing of initiation, and whether a progestogen is used. Treatment should be individualized using the best available evidence to maximize benefits and minimize risks, with periodic reevaluation of those benefits and risks of continuing therapy.
As we know, there are various hormonal replacement therapy treatments for menopausal symptoms. Estrogen therapy is for women who do not have a uterus or women who have had a hysterectomy. Unopposed estrogen is not good for women who have a uterus because it increases the risk for uterine cancer. Benefits of estrogen therapy are decreasing symptoms caused by menopause, such as local symptoms, vaginal dryness, painful sex, vulvovaginal atrophy. Some systemic symptoms that it helps to decrease are vasomotor symptoms, commonly hot flashes and night sweats. It also reduces the risk of osteoporosis, colorectal cancer, dementia, diabetes mellitus, and it has a potential cardioprotective effect, although it has been controversial in studies. And lastly, reduced risk of urinary incontinence. Estrogen therapy risks include increased risk of cancer, such as endometrial cancer with unopposed estrogen in women with a uterus, breast cancer, and ovarian cancer, increased risks of stroke, vein thromboembolism. Adverse effects include nausea, bleeding, bloating, breast tenderness, swelling of extremities or water retention, headaches, hair loss, and dizziness. In counseling on the risks and benefits of estrogen therapy, it's important to perform a health assessment, which includes a health history, mammogram, and physical exam, which are needed to create a risk profile for each woman. Each woman is different, so each risk profile should be done individually and comprehensively. We need to assess for contraindications and areas of caution, such as those who are lower risk, those who had recent menopause, who are of normal weight, normal blood pressure, relatively healthy, active female. Those would be considered lower risks. Those who have diabetes, who smoke, have uncontrolled hypertension, obesity, live a sedentary lifestyle, and have limited mobility would be considered more moderate risk, and we should exercise caution. Those with also uncontrolled cholesterol levels, because estrogen is processed within the liver. So if we're having issues with the liver, we're going to have more issues processing that estrogen as well. Also, those who would be considered higher risk and should avoid hormone therapy are those with known venous thrombosis or pulmonary embolism, a PE, those with stroke, heart attack, clotting disorders, known breast cancer, and those who have other cancers as well, because we're unsure about how estrogen might affect those estrogen dependent cancers. Also, we need to empower the patient to be active in estrogen therapy decision making. We want to make sure that the patient is making an informed decision to proceed with care if that's what they decide, once benefits of hormone therapy outweigh the risks. Therapy has multiple delivery routes depending on the symptoms. So we have local symptoms would be treated with local routes, such as the creams, tablets, or ring, while systemic forms to treat systemic issues are tablets, patches, creams, sprays, and gels. So we'd want to counsel the woman on all these factors so that she can make the best decision guided by her midwife. It is also important to note that when prescribing estrogen therapy, it is important to start with the lowest dose first to prevent having as much adverse side effects as possible. Also, if a woman is having local symptoms, then we're only going to treat her locally versus treating her systemically for local symptoms, predisposing her to a risk of estrogen therapy, such as stroke or cancers, etc.
As mentioned earlier, unopposed estrogen can only be utilized for hormone replacement therapy in women who do not have a uterus because can proliferate the growth of the endometrial lining and lead to cancer cells developing. So, for women who still have their uterus, estrogen therapy with progesterone can be utilized. And the progesterone aspect protects the uterus from overgrowth of endometrial lining, which can lead to the endometrial cancer. And progesterone can also be given during the perimenopausal time period to treat hot flashes for women who are unable to take any estrogen at all. So it is an option for those women who are at higher risk and are unable to take estrogen. There are some risks associated with progesterone use in hormone replacement therapy. The rate of breast cancer does appear to be higher in patients utilizing estrogen and progesterone therapy rather than the women just using estrogen therapy, especially when used more than 5 years. So the goal for obviously all of these treatments is to utilize the smallest dose over the shortest amount of time to give the most benefit with the least amount of risks. Progesterone also has some side effects that can these are breast tenderness, headaches, migraines, mood swings, depression, acne, abdominal pain, back pain, or vaginal bleeding. These typically occur in the first few weeks of use and typically will resolve after that. If they continue, the provider can switch to a different route of administration or lower the dose of the progesterone.
Testosterone is not as adequately studied or recommended as estrogen and progesterone for hormone replacement therapy However, it is still utilized in some women. Women naturally produce testosterone and it declines just like the other hormones in pre- and postmenopause. Typically, testosterone is given when a woman experiences a decrease in sexual interest and desire. Some of the most reported and noted risks for testosterone replacement are acne, hair growth, reactions at the site where the patch is, and that it can take anywhere from weeks to months to notice effectiveness. These risks are usually reserved to the site where the patch is placed with less systemic effects. Some of the benefits of testosterone replacement therapy are an increased sexual drive, more satisfying sexual experiences, including desire, arousal, and orgasm, increased bone density, increased energy levels, mood, and concentration, and improvement in motivation. Bioidentical and custom compounded hormones are used pretty often with hormone replacement therapy, but they still come with their own set of risks. Bioidentical means it comes from either plant, animal, or natural sources and is identical to human hormones. Some of the risks with these types is that they are actually synthetic because hormones cannot come from those sources, meaning they are created in a lab. Most people are unaware of this, so they believe they are more natural and safer than hormone replacement therapy. The benefits are that since these are synthetic, they are usually FDA approved and can be prescribed safely like other hormone replacement therapy. Custom compounded hormones are products created specifically for patients from a serum or saliva sample. There are many risks associated with these, with the biggest being they are not FDA approved and there is no oversight. This means there is no proven safety, effectiveness, purity, potency, or quality. It is also expensive to have the sample analyzed and custom product made, which may put women in a stressful situation financially. Surprisingly, 1/3 of women in the United States use this type of hormone replacement therapy. This is likely due to the fact that most are unaware of the lack of FDA approval or risks associated. There are no known benefits, which is likely from the lack of approval and research. Many products are advertised as safer and more effective than hormone replacement therapy, but studies have not shown that. This graph shows when to avoid and initiate hormone replacement therapy. For example, if a woman does not have hot flashes but has vaginal dryness or painful intercourse, and also a type of hormone-sensitive cancer or history of it, hormone replacement therapy is not recommended. This is because of the increased risk of cancer.
So there are a variety of benefits and risks associated with hormone replacement therapy, and there's no one size fits all answer to hormone replacement therapy. Patients and their providers must individually weigh the potential risks against the potential benefits of hormone replacement therapy. Each woman's experience with menopause is very different, and not all women will need hormone replacement therapy, nor will they want it. For the women that do want it, typically treatment should be the lowest dose possible over the shortest time period possible to minimize the risks associated with hormone replacement therapy. And then things that they should be reviewing are the patient's age, the treatment options, the cost of treatment. All these things need to be evaluated initially, and then if a patient does decide to do hormone replacement therapy, these things should be reevaluated periodically during treatment as well to make sure that the benefits still outweigh the risks at all points during therapy.